That's a very broad question you're posing me. I think hematology has gone very much forward. I wouldn't say what are the unmet needs, what we are developing in order to obtain major results, and that is always more targeted treatment. It is always more identification of new genetic abnormalities. It's always more, if I may say, and it's very important, the fact that we are designing progressively more chemo-free protocols. And I would add the changes are very important in the sense that for many diseases we can monitor what we call minimal residual disease, mainly with molecular technologies. And I think that is filling a gap, let's put it that way. That we're going to be much more precise to an extent that many clinical trials, certainly for acute leukemias, are tailored according to minimal residual disease. So if I go back to the older days and compare today, I think in the old days we had less impact by the laboratory. Nowadays, integration between the laboratories, not the laboratory, and many laboratories which play a key role in hematology are part of the clinical practice. And that I think is a change. This is changing or evolving into answering some of the unmet needs and neoplastic malignancies. This is, I mean, again, this is, the other one was a bit of a question, goes a bit to the past. This is going into the future. I mean, it's clear that this has been a very important year in terms of, I would say, the development and the recognition of the impact of immune-mediated strategies. To an extent that this year the Nobel Prize for Medicine has been given to two colleagues for advancements exactly in that, in checkpoint inhibitors. So it's a bit a year of immunotherapy. So in this line, the CAR-T have certainly generated a great degree of expectations, and I would say also of important results. And CAR-T have already been approved by FDA first and by EMA just after for the management of acute lymphoblastic leukemia in children and young adults with refractory or relapsed disease, and also with diffuse large B-cell lymphoma, again relapsed or refractory. So that is an opening area with these engineered autologous T cells from patients, which is obviously a very exciting step forward. What can I say? I mean, these CAR-T are going to develop further, undoubtedly, and they are inevitably going to be utilized earlier in patient management or course of the disease. It'll take time, that's where we're going. So if that happens, and it will happen, and they show to be effective in controlling or maybe hopefully eradicating minimal residual disease, then I think the issue of transplant, which is not so much autologous, but I would say allogeneic, may be that we may reduce the number of allogeneic transplants. I see the development of CAR-T as a way to prevent relapse from patients. The approval, I said, is for relapse refractory in two conditions, but this will extend. Moving them forward, we hope to reduce the number of patients who actually relapse, which is a real goal of treatment in cancer, to cure patients. If that is the case, then I think that in the near future we will probably, for many conditions, or some conditions, we will see reduce the number of allogeneic stem cell transplants. Well, I mean, this is a bit what we just said. I mean, I think if we look at this past year, the most exciting data come from probably CAR-T cells. So, I mean, I don't want to repeat myself, but if you really talk about the most innovative in hematology, that is probably the most exciting new part. You know, I'm old enough to remember how many studies we performed over years and decades on immunotherapy and hematology with ups and downs, but there have been more downs than ups. So this is a time when results with an engineered autologous lymphocytes are potentially very exciting. So I think that is probably the most important. The other, again, I partly mentioned, is the fact that I think that we are progressively developing more chemo-free strategies for patients with hematological malignancy. This is a major step forward. I mean, I give an example. We can control 3 leukemias without chemotherapy. Maybe not for all patients, but for many. I mean, the example of one acute leukemia comes from acute promyelocytic leukemia, where we can cure many patients without systemic chemotherapy. Chronic myeloid leukemia, it's not this year, obviously, but I mean, in the old days, the only possibility of cure was a transplant. now with the tyrosine kinase inhibitors, patients live more or less like the normal population, match per age without CML. In the old days, the median life expectancy was around 4 years. Even acute lymphoblastic leukemia with the BCR-ABLs or the Philadelphia chromosome, the most frequent genetic subgroup in adults, they do well with the tyrosine kinase inhibitor. They go into remission without chemotherapy. So these are major changes. I think we have seen an extension of these chemo-free strategies. And combined with the immunotherapy we discussed earlier, I think this is the major change that we're witnessing. Yeah, well, I mean, I think this has been one of the most exciting developments here. Not unexpected. I mean, I work a lot on CLL, so nothing that is unexpected, but it is clear that with the new drugs that have been developed over the last years, that are biological drugs. We're going back to the targeted treatment I mentioned earlier. In CLL, are not targeting a genetic abnormality, but are targeting pathways which play a key role in maintaining the disease. So here we've had a lot of presentations on the impact of the combination of the new drugs, the BTK inhibitors, the anti-BCL2, with or without anti-CD20. So this is all non-chemo in combination. So this, I think, is one of the most important developments, let's say updated results, because it's not something we didn't expect, but the data are starting to become mature and presented here. My concern, not a concern, but I mean, I think we have to be worried, because I think people go home from ASH thinking that for CLL, for all CLL patients, treatment should be with all the new drugs in combination. So this is very important, but it opens a number of questions. A, should it be for all patients or not? Do all patients require all this? Because some patients maybe can be controlled with more conventional treatment, particularly those with a biological profile which is more favorable. And the final point that I would like to put, and that ties a bit together all the things we discussed, there's an issue of sustainability and accessibility. I mean, can all these new drugs, these new treatments, we talked about CAR-T, how available will it be? How accessible will it be? There's an issue, who's going to pay for all this? So these are points that I think we have to keep in mind. And I think that we have to, in order to optimize resources, we have to try to aim at identifying which patients should benefit from the most advanced form of treatment, and the patients who instead can still benefit from more conventional. So CLL is one example, great data here, but I don't think it's the end of conventional treatment, which for CLL is chemoimmunotherapy. It's a matter of tailoring patients, identifying which to go to one or which to the other. So that, I think, is a very important development in CLL. And if I have a final point, we're talking about CAR-T in CLL too. So we want to look ahead. If we speak again next year or 2 years' time, we'll hear a lot of CAR-T even in CLL, maybe for the patients with a very unfavorable genetic profile.